Good morning, everyone, and welcome to a very special Grand Rounds presentation. Today, we are celebrating the memory of an exceptional physician and surgeon, Dr. Eugene Weiner. I'm Dr. Brian Martin, the Vice President of Medical Affairs. I'm here at Children's Hospital, and I'm joined in the flesh with Dr. Lee Bierman here in our office, who's this year's Weiner Award winner. I'd like to open with a few moments to think about and remember Gene. At the time of his passing in 2006, Gene was the Executive Vice President and Chief Medical Officer here at Children's Hospital of Pittsburgh. Gene was a tireless advocate for patient safety and quality in pediatric care. A visionary in the power of the EHR and advancing patient safety, he led Children's as an early adopter of computerized order entry in 2002 as the first pediatric hospital in the nation to do so. In this regard, Dr. Weiner's efforts resulted in the reduction and elimination of potential medication errors. Dr. Weiner earned his medical degree at Medical College of Virginia. He completed a surgical internship and was a junior resident at Medical College of Virginia before entering the military in 1966. During his 2-year service, Dr. Weiner served as a surgeon at Vandenberg Air Force Base and as commander of the 552nd Medical Service Flight Team and Deputy Chief Health Officer, Cord 3 Corps in Vietnam. He received his training in pediatric surgery at Children's Hospital of Pittsburgh and the University of Pittsburgh School of Medicine, was named Professor of Pediatric Surgery in 1992, and appointed Medical Director and Surgeon-in-Chief in 2001. Dr. Weiner was an active member of numerous professional societies and held several national positions, including advisor to the American Pediatric Surgical Association, president of the APSA's Training Director Program and Board of Governors, and also our state chairman in the Commission on Cancer. Dr. Weiner had a longstanding interest in the management of children with cancer, involvement including senior surgeon on the intergroup Rhabdomyosarcoma study group, and also serving on Children's Oncology Group, the nation's largest clinical research organization devoted to pediatric cancer. He reserved several research grants to investigate aspects of pediatric cancer treatment and published extensively on surgical oncology, venous access, including more than 90 articles in peer-reviewed journals and 20 book chapters. On a personal note, Gene served as a very kind mentor to me early in my career here at Children's, particularly when I was a newly minted division chief. He provided guidance and counsel as I was able to help grow my service, as well as integrating the Cleft and Craniofacial Center to our service lines here at CHP. He is an extremely dedicated surgeon to his patients, families, staff, and to the CHP community, and actually also operated on my cousin in the late 1970s. So we have a personal family connection. I'd say overall, Gene exemplified the essence of servant leadership. I'd like to take a moment of silence to remember Dr. Weiner. Thank you. I'd now like to invite Jeff Weiner, Dr. Weiner's son, for a few remarks from the family. Jeff?
Thank you, Dr. Martin. Just wanted to thank everybody again for joining us this morning. It's been 15 years actually this year since my father passed. So proud to still have his name and legacy remembered by Children's Hospital, as well as this award. Congratulations to Dr. Bierman. Something interesting, last year, my cousin, who would have been my father's great nephew, was 11 years old, was diagnosed with rhabdomyosarcoma, started in his foot. This past year, he had to undertake months and months of therapy and the chemotherapy, and radiation treatment. And fortunately and luckily, he was diagnosed as being in remission just this past month. So I'm very happy to say that. And it's interesting, since my father was part of the intergroup of the rhabdomyosarcoma study group, I'm sure he would be thrilled to death to hear what's happened, and hopefully, Alex will make it through and, we'll have a long life to lead. And again, I just want to say thanks again, to everybody, and look forward to the presentations. Thank you so much.
Thank you, Jeff, and thank you and your family for taking the time and support and joining us every year here to remember your father's legacy. Thank you. It now gives me great pleasure to introduce Dr. Lee Bierman as the Wiener Award recipient for 2021. I can't say enough about Dr. Bierman. We had over 60 nominations for the Wiener Award this year. So 60 different individuals were nominated, and Dr. Bierman really came out at the top. I want to share with you, we'll share with you some of the comments and overwhelming support he had from the Pediatric Cardiology Division. He is noted to be, quote, a true gentleman who's devoted to the best outcome for his patients. He inspires excellence throughout our cardiology division, all while maintaining an incredibly gentle and unassuming personality. He motivates his patients, young and old, to take care of themselves and motivates his colleagues to be the best they can for their patients. Finally, he was described as the heartbeat of the cardiology division. I've had a great pleasure of serving with Lee as professional staff president and colleagues in service to the professional staff. And I can't say enough, Lee, about how happy I am to hear you, to have you here today and to hear that you are the Wiener Award winner for this year. So with that, I'll turn it over to you. Thank you.
Thank you very much, Brian. Thank you for reading the introduction that I wrote for you. Very nice job.
Oh, you did a nice job with it.
Yeah. It's a real honor to receive this award. And one of the virtues of longevity, which is one of the few virtues that I will admit to, it enabled me to spend a lot of time with Dr. Wiener. I had the opportunity to work and observe him in action from early in his career and see him grow into a giant as far as making Children's Hospital what it is today and achieving the excellence in patient care and patient safety. I remember many times being in his office over the years with the complex patient issues when he was medical director. And I still see him sitting back in that chair, very relaxed, listening to everything, being quiet for a while, not having too much to say except something very cogent and helpful at the end of the discussion and helping us through some difficult situations. So it's truly an honor to receive an award in his name. It's also very humbling when I think about Dr. Wiener's legacy, as well as the previous awardees of this award. And the other thing is just walking the halls of Children's Hospital. You just look around, you see so many people who every day make contributions to Children's Hospital to make it a better place and to achieve the vision that Dr. Wiener had for making it one of the most outstanding institutions in patient care and patient safety. So I want to thank you, Brian, and anyone else that had anything to do with this award, and accept it very humbly.
Thank you, Lee. It's now our pleasure to introduce Dr. Allison Solbon from Adolescent Medicine as our Wiener lecture speaker. Dr. Solbon is a member of the Adolescent Medicine Division and an assistant professor of pediatrics, public health, and clinical and translational science here at UPMC in Pitt. She received her medical degree from the University of Pennsylvania and a master's of public health from Harvard. Her residency and fellowships in pediatrics were from the other children's hospital in the state, Children's Hospital of Philadelphia and Hospital University of Pennsylvania. Her work, which we're really excited to hear about today, models social networks to study associations between adolescent and adult connections in multiple forms of youth violence prevention, particularly in community-based approaches. Through an implementation science framework, she seeks to translate the findings into a community-based violence prevention intervention that leverages our connections, our institutional connections and community connections, and safeguard youth. She also investigates novel methods to study how physical and social environments shape youth violence risk. We look forward to your lecture here, Dr. Solbon, and I will turn the podium over to you. Thank you.
right. Let me get this set up. And are you all able to see slides? All right.
Yes.
Perfect. Good morning, everyone. It is such an honor to be speaking today as part of this lectureship and to be here to celebrate the legacy of a true champion of pediatric health. So thank you very much for the opportunity. I have no conflicts of interest to disclose. And for the time together this morning, I've set forth 4 learning objectives that you can see outlined here to really organize our time together. On November 8th in 2018, the National Rifle Association tweeted, "Someone should tell self-important anti-gun doctors to stay in their lane. Half of all articles in Annals of Internal Medicine are pushing for gun control. Most upsetting. However, the medical community seems to have consulted no one but themselves." And this tweet was issued in response to a position paper put forth by the American College of Physicians on public health approaches to reducing deaths and injuries from firearms. And in response, Dr. Joseph Sakharine, who's the director of emergency general surgery at Hopkins, created the hashtag "This is our lane," which subsequently went viral. And he tweeted, "As a trauma surgeon and survivor of gun violence, I cannot believe the audacity of the NRA to make such a divisive statement. We take care of these patients every day. Where are you when I'm having to tell all of those families their loved one has died?" In an NPR interview, Dr. Sakharine discussed the graphic nature of some of these responses and said, and I quote, "By seeing a lot of these photos of bloodstained scrubs or an empty waiting room, it's made it real." And in this op-ed that was written by Dr. Megan Rainey and colleagues, they argue that the "This is our lane" hashtag, and I quote, calls attention to the role of physicians from many walks of medical life and encompasses interdisciplinary colleagues as well. Paramedics who face carnage in the field, nurses who provide massive transfusions, housekeeping staff who clean blood-soaked floors, and everyone who helps survivors piece their lives back together and helps families recover from loss. This is their lane too. And as we spend about the next 45 minutes focused on violence prevention, I want all of us to consider the roles that we play from the small to the large every day in framing violence prevention as a public health and health equity issue, and the ways that we can do an even better job of working together to keep children and teens safe. And so firearm-related injuries actually now outpace motor vehicle collisions as the leading cause of death among US adolescents and young adults between the ages of 12 and 24. And these rates within the US far exceed those rates in other high-income countries. And what I have depicted here are the causes of death among US children between the ages of 1 and 19, where firearms, as you can see, are the second leading cause of death. And you can see this uptick in the last several years as well. And in addition to fatal injuries, we also know that non-fatal violent injuries actually outnumber fatal by more than 100 to 1, such that each year over 400,000 youth seek care in US ERs for non-fatal assault injuries. And we also know far too well that violent injury and death disproportionately impacts minoritized youth, and particularly young Black males living in neighborhoods made vulnerable by structural inequities, with homicide rates up to 10 times higher for Black youth compared to white youth. And there's an urgent need for approaches that address the underpinnings of these racial inequities. And if we want to look more specifically here in Pittsburgh, I've pictured 2 maps that represent data from 2020. On the left is a map of Allegheny County, and on the right is zoomed into the city of Pittsburgh. And these look at homicides across the county and city respectively in 2020. And over that 1-year period, there were a total of 109 homicides within our county, which actually represents a 16% increase compared to 2019. and is similar to trends that we've seen in other cities across the nation in the 2020 year. And in every single one of these for which there's data, a firearm was the mechanism of injury. And 1/3 of the victims in 2020 were between the ages of 15 and 24, and 94% of the youth victims were Black males. And so far in 2024, 34 young people between the ages of 0 and 24 have died by homicide in our county. And if we look more broadly at the violence that doesn't necessarily reach medical attention, it's even more prevalent. So looking at data from the 2019 Youth Risk Behavior Survey, 1/4 of youth have been in a fight in the last year. 16% have carried a weapon in the last month, and about 5% have carried a gun in the last year. And again, similar to trends with homicide, minoritized youth bear a disproportionate burden of violence victimization and witnessing. And one of the really critical pieces here is that COVID-19 has tremendously transformed the epidemiology of violence experienced by adolescents and young adults, and has also had significant impacts on a range of youth serving programs and services that are designed to prevent violence as well as to mitigate and address the consequences of violence exposure. And I had the opportunity to co-author this commentary together with Drs. Ragavan and Dr. Miller, as well as Fatima Muhammad, who's the director of the Health Alliance for Violence Intervention. And in this piece, we articulated some key priorities around supporting young people who are exposed or involved in violence in the context of a pandemic, really focusing on the importance of confidentiality and safety in instances where we're using telehealth and virtual visits, and focusing on universal provision of resources and education in all patient encounters, as well as really rethinking innovative ways to partner with community-based organizations. And I also want to reflect on the fact that there were wide variations in terms of the way that community-based violence prevention providers were thought of and incorporated or not incorporated into the COVID planning strategies in the early stages of the pandemic, which had broad implications for health equity, not only for the patients that we serve, but for providers themselves in terms of whether or not they were designated as essential workers and therefore given opportunities for early vaccination and continued in-person work or not. And we learned important lessons about the importance of recognizing community-based violence prevention workers within the essential workforce as being critically important to supporting health equity in the context of a pandemic. And before we dive into the meat of the lecture, I want to first start with a couple of definitions. And I like this framework that's put forth by the World Health Organization on typologies of violence. And the WHO defines violence as the intentional use of physical force or power, threatened or actual, against oneself, another person, or against a group or community that either results in or has a high likelihood of resulting in death, injury, psychological harm, maldevelopment, or deprivation. And you can see depicted along the left that there are 4 modes in which violence can be inflicted in this model, and that includes physical, sexual, psychological, and deprivation. And then there's 3 overarching violent subtypes based on the victim and perpetrator relationships. And this includes self-directed, interpersonal, and collective violence. And today we're going to be focused here at the interpersonal and particularly around the community violence level. And when we look more specifically at youth violence, this is defined by the CDC as the intentional use of physical force or power to threaten or harm others by young people ages 10 to 24. And it usually involves young people hurting peers who are unrelated to them, who they may or may not know well. And it can include things such as fighting, bullying, threats with weapons, and gang-related violence. And young people can be involved as victims, as perpetrators, as witnesses, or as any combination of the above. And as I outlined on that learning points slide, one of my key priorities for today is to frame violence as a health equity issue. And in doing that, one conceptual model that I really like comes out of the National Academies of Sciences, Communities in Action, Pathways to Health Equity report. And here they argue that healthier, more equitable communities require, first, making health equity a shared vision and value. Second, fostering multi-sector collaboration. And third, increasing community capacity to shape outcomes. And as you can see here in this model, the health sector intersects with so many other sectors to shape the lived experiences and outcomes for the young people that we care for. And I want to pause for a moment here to really reflect on and recognize the young people who've been lost to violence in our city. And, the killing of so many young people in our city, including Antoine Rose, who was shot and killed by a police officer here in Pittsburgh in 2018, and all of the young men and young women who have died by violence in our city, and the grief and loss that impacts those they leave behind is absolutely a health equity call to action. And the murder of George Floyd really sparked newfound national recognition in what has been a long-standing and insidious injustice in our country. And I think it's imperative that we think about how we as healthcare providers, as well as the health systems that we work in, can really work together to address the long-standing inequities and prevent violence. And this is an imperative piece of our mission as pediatric providers to safeguard the health of all of the children in our care. And although we have made progress towards racial equity, there's clearly a lot of work that remains to be done. There is a robust body of science articulating clear evidence to support ongoing negative impacts of racism on a broad range of health and well-being outcomes. And if you haven't had a chance to read this position paper yet, I urge you to make time to do so. And in this paper, the authors argue that by acknowledging the role of racism in child and adolescent health, that we as pediatricians and pediatric healthcare providers are incredibly well positioned to proactively engage in strategies to address racism at multiple levels of the social ecology and thereby improve the health of all children and families. And I think within this position statement, the authors use examples from the education and juvenile justice systems. And in many instances, those same points really translate to the field of violence prevention as well. And I want to take a minute to talk about some work looking more locally here, thinking about how experiences of discrimination impact the lives of young people here in Pittsburgh. And we were really interested in this piece in looking more locally about these experiences of discrimination and how they shape health, mental health, and violence outcomes among youth in Pittsburgh. And this work was led by Dr. Golan and also included multiple authors within our department, including Dr. Stokes and Dr. Zocco. And in this paper, we used an intersectional approach. And by that, I mean looking at multiple different facets of identity and jointly considering experiences of discrimination based on race, sexual orientation, gender identity, religion, immigration status, as well as physical or mental disabilities. And in this study, we used data from an anonymous school-based survey that was conducted among just under 4,000 9th through 12th graders across 13 public schools in Pittsburgh in 2018. And in this sample, the mean age was about 15 and a half. Just over half of participants were assigned female sex at birth. 36% identified as Black, 9% as Hispanic, and 19% as multiracial. And we're focused in this paper on what's called identity-based bullying, or IBB for short, which is looking at experiences of bullying or discrimination based on different facets of one's social identity. And in this survey, 4 out of 10 teens reported identity-based bullying victimization. And just over 1 in 4 reported identity-based bullying perpetration, and just under a quarter reported both. And across all the different types of social identities, the racial and ethnicity-based bullying victimization was the one most commonly reported. And what I want to highlight here is that youth who had multiple stigmatized identities experienced even higher rates of IBB victimization. Specifically, the highest rates of IBB were reported by gender diverse Black and Hispanic youth, wherein 3 out of 4 young people who participated reported these experiences. And so what does this mean for health, mental health, and violence-related outcomes? So this table represents findings looking at associations between, in the left-hand column, IBB victimization, and the right-hand column, IBB perpetration, and how those are related to a whole constellation of outcomes. And the take-home message here that experiencing identity-based bullying based on multiple stigmatized identities was associated with every single outcome that we looked at, including delayed well care, foregone medical care, non-suicidal self-injury, suicidal ideation, and greater violence involvement. And I think these findings highlight, along with a large body of existing scholarship, the critical need for all of us as pediatric health providers to address racism and its ongoing and pervasive impacts on health. And so how do we actually do that? I want to point out a resource that's free and publicly available within Reaching Teens, which is a curriculum put forth by the American Academy of Pediatrics. And this chapter is the one that's available without charge, and is titled "The Traumatic Impact of Racism and Discrimination on Young People and How to Talk About It." And what I like so much about this chapter is that it really takes a strength-based approach, as does the whole curriculum, and also provides tangible strategies for how to engage young people in discussions around racism and its impacts in really strengths-based and youth-led ways. And so I encourage anyone who's interested to take a look. And in addition to really thinking about violence as a health equity issue, it's also really important that we think about violence in the broader context of the lives of young people and their families. And historically, so much research as well as intervention programming has really been done in this siloed way, focused on single types of violence. And this Connecting the Dots report that was put forth by the CDC was really critical in pushing the field forward, in helping us to identify shared risk and protective factors across multiple types of violence, and really pushing all of us that work in the violence prevention research space and intervention space to better coordinate and integrate our responses across types of violence in a way that really recognizes young people's embeddedness within social networks, within family and neighborhood contexts, so that we can create interventions that are more responsive to their needs. And in addition to the report, the CDC has actually put together a great suite of resources on the Connecting the Dots site, and I've included the link down there. And it provides this really nice visual display about sort of what we know about cross-cutting risk and protective factors against multiple types of violence. And I'm going to use this in a couple of screenshots to walk through some of the key protective factors in the next couple of slides. And so here, focused in on the relationship level, I want to draw your attention to a couple of things. First, the important role of family support and connection in protection against multiple forms of violence. And this includes youth violence, bullying, teen dating violence, suicide, and child abuse. And relatedly, we see similar protective effects of natural mentors, so adults outside the family who provide support against youth violence, teen dating violence, and suicide. And when we broaden out to the community level, I think one of the most clear things is that we see lots of red. So we know a lot more about risk factors at the community level than we do about protective factors. However, we do see similar cross-cutting protective effects of this community support and connections across multiple types of violence prevention. And really motivated by this Connecting the Dots framework, we wanted to understand patterns of violence co-occurrence and how they relate to some of these cross-cutting protective factors among young people most impacted by community violence. And to look at this question, we use data from a community partnered cluster randomized sexual violence prevention trial that was carried out across 20 disadvantaged neighborhoods here in Pittsburgh. And the study included 868 adolescent males between the ages of 13 and 19 who were recruited through youth-serving community agencies between 2015 and 2017. And the study included multiple surveys at different time points. The data I'm presenting here use the baseline and end of program surveys. And as you can see outlined on this slide, we looked at multiple different types of violence as well as several key cross-cutting protective factors. And in this analysis, to look at this comprehensive overview of participants' engagement in all the risk and protective behaviors that we were including, we actually used an approach that was similar to a genetic analysis. But here, rather than looking at sort of which genetic markers are highly correlated, we were looking at which violence outcomes were highly correlated. And so to do this, we actually calculated an odds ratio for the over 3,000 risk and protective behavior combinations within this data set and presented this in an odds ratio matrix, which you can see sort of depicted in cartoon format here. And we then normalized this odds ratio matrix, which allowed us to do comparisons across the various study questions. And then we use this normalized matrix to conduct hierarchical clustering to look at which protective and risk behaviors were most strongly co-occurring. And then the output from this hierarchical clustering was visualized using dendrograms and heat maps that I'll walk through in the next couple of slides. And so this slide depicts the dendrogram looking at the clusters of risk and protective behaviors, and the results here demonstrate kind of the degree of similarity in these odds ratio patterns between the survey items. So those items that appear most closely within this dendrogram are more similar. And from this analysis, we actually saw that 7 overarching clusters emerged, including school engagements, career and future aspirations, substance use and bullying victimization, childhood adversities, delinquency and sexual violence victimization, sexual violence, youth violence and bullying perpetration, dating abuse perpetration, and sexual and partner violence perpetration. And from here, we created heat maps, and the heat maps actually depict the relative strength of the associations across the different risk and protective behaviors. And the red squares demonstrate the kind of strongest co-occurrence or hotspots. And the areas that are bluish in tone are those with minimal co-occurrence. And so I think eyes draw directly to that spot down there. So what's that? So actually that strongest hotspot occurred among the sexual violence perpetration items. And we did see other hotspots that emerged between sexual violence victimization, bullying victimization, and endorsing exposure to childhood adversities. And then importantly, youth who identified positive future orientation and strong career aspirations were unlikely to endorse sexual or weapon-related violence perpetration. And then the other key protective factor that emerged was around school engagement, which was inversely related to physical and sexual partner violence perpetration, as well as to substance use. And to circle back now to the connecting the dots and looking at these cross-cutting protective factors, we were really interested in understanding whether or not the co-occurrence patterns differed based on the presence or absence of various forms of protection. And so here what we did was actually use a measure of social support, which was a 3-item question, to sort of split the sample into those on the right who endorse high levels of social support and the young people on the left who endorse lower levels of social support, and then repeat that whole analysis looking at the odds ratios, the clustering, and recreating the heat maps among those 2 subgroups, and really trying to understand if there were any differences in co-occurrence pattern based on the presence or absence of social support. And so I want to just highlight a couple of key takeaways in the interest of time. And what we saw is actually that the group on the right with the high social support actually had larger magnitude, so a deeper red color here, of the direct associations between those sexual violence perpetration items. And there was actually more co-occurrence of sexual violence perpetration with bullying and youth violence perpetration. And also sticking with the high social support group, that future orientation and career aspiration showed stronger inverse or protective associations across multiple different forms of violence compared to those with less social support. Whereas in contrast, in the low social support group, that school engagement really rose to the forefront and was strongly inversely related to sexual violence perpetration. And so in addition to looking at all of these sort of clustering and more exploratory analyses, we also looked at more standard associations between two cross-cutting variables that I had mentioned in that connecting the dots framework. So again, looking at social support as well as natural mentoring. And here we found inverse associations between both social support and natural mentoring with gang involvement and sexual violence exposure. And so pausing for a second, sort of what are some of the key takeaways from this approach? I think, in keeping with prior research, our findings again highlighted how youth who perpetrate one form of violence are likely to also be perpetrating or involved in other forms of violence, with that strong hotspot really occurring among the sexual and dating violence perpetration items. And I think this really reiterates the need for us to be thinking more holistically and in integrated ways about how to support young people who are exposed to or who are involved in violence. And so in the remaining time together, I want to really focus on evidence-based and evidence-informed approaches that all of us in our various roles can use to support children and families who have been impacted by violence. And so in the post-injury period, what do we know about this time? We know that the strongest risk factor for violent injury is actually a history of previous injury, with re-injury rates as high as 45%, and actually a risk of future death being twice as likely due to violent injury for someone who's sustained an initial violent injury. And in this recent study by Cunningham and colleagues, who looked at a prospective cohort of 350 assault injured youth who presented to the ER, they found that 37% sustained a recurrent injury requiring ED care within 2 years of that index event. In our own work in Philadelphia, where I was before joining the faculty here in Pittsburgh, among a cohort of 100 violently injured youth who were cared for at Children's in Philadelphia, we found that the highest risks of re-injury were actually in those immediate weeks following discharge from the emergency room. And we also found that retaliatory intent is important, such that young people who at that baseline visit discussed intent to retaliate actually had 5 times higher risk of threatening someone and twice the risk of weapon carrying in the weeks following that initial injury. And what we know is that kind of in the absence of dedicated intervention programs or support services, young people are often discharged following a violent injury, sort of the same contexts where they were injured, without additional resources to help them manage peer pressure or help them stay safe. And I think that we've really been moving to envision this post-injury period as an important opportunity for intervention. And I want to urge all of us sort of working in this pediatric health space to think about ways in which we can be involved in helping to identify some of those cross-cutting protective factors, working from youth strengths, and helping to identify those positive connections and linking young people to services. And so I want to actually provide a brief history and an overview of hospital-initiated violence intervention programs, or HVIPs for short. And back in 1994, Youth Alive, which is a nonprofit organization that's based in Oakland, California, established the first HVIP program, which is still in existence, called Caught in the Crossfire. And since then, a whole group of programs has sprung up across the country and internationally, including our ET3 program here that I'll speak to in a moment. And every single program is different and has unique components, but overall, there are kind of 4 overarching components that are included in this HVIP model, and that includes interdisciplinary involvement, comprehensive assessments of needs and goals, individualized case management, and navigation to services. And HVIP teams often include physicians, mental health professionals, community partners, and violence prevention professionals who are working together to provide crisis intervention, community-based services, mentoring, and case management. And kind of the intensity and duration of involvement is really dependent on young people's needs and goals, but is often on the range of sort of 6 months to a year. And in 2009, Youth Alive actually convened the first symposium on hospital-based violence intervention, from which a national network now known as the Health Alliance for Violence Intervention was born. And the Hobby is an organization of over 40 HVIPs within the US and internationally that all work together to really focus on hospital and community collaborations, with a central piece being around health equity and trauma-informed care to advance the fields of violence intervention and prevention. And here at Children's Hospital in Pittsburgh, I have the distinct privilege of directing our Empowering Teens to Thrive, or ET3 program for short, wherein we support young people between the ages of 12 and 25 who've been hurt and seek care either in our emergency department or hospital, or more broadly in our outpatient settings, with the overarching goal of promoting healing and reducing re-injury. And our program is located out of our Center for Adolescent and Young Adult Health, or CAYA, in Oakland. And we also provide inpatient consultation for patients who are admitted. And we provide really individualized, detailed assessments around an education and counseling, and then work to link youth and families to support in their neighborhoods. And with support from the Hines Endowments and the Allegheny Health Department Office of Violence Prevention, as well as a recent grant from SAMHSA, we've been able to create a community-based one-on-one mentoring program where we pair young people who've been involved or impacted by violence with a tremendous network of mentors with expertise specifically in supporting young people involved in violence. And so when we work in these kind of settings, thinking about this really individualized approach to intensive linkage to services, what do we learn from these initial assessments? And this paper I'm presenting here comes from work that I did while in Philadelphia, working with the Children's Hospital of Philadelphia VIP program. And in this piece, we examined the self-identified post-assault needs of 50 adolescent males participating in the VIP program there. And most of the participants in this study were treated for non-penetrating injuries and discharged directly from the ER. And importantly, almost 2/3 reported clinically significant traumatic stress symptoms, highlighting the fact that even young people who suffer more minor injuries are in need of support or could benefit. And what I have here depicted on the right is a summary table of needs and goals, wherein 89% of the young people actually self-identified mental health needs following injury. And legal and educational needs were also commonly identified. And I think one of the key takeaways here is that youth-focused early intervention services, and particularly services directed at mental health, are acceptable and desired, and that in spite of these recognized needs and goals, often many different barriers get in the way. And I think that's where all of us in this pediatric health space can really contribute, because I think this is very much within the purview of pediatric health and thinking about how we can extend our models of embedded care and how we're well positioned to think about both the medical and mental health needs among violently injured youth. And this really creates opportunities for us as pediatric health professionals to partner with HVIP programs to support youth. And so what do we actually know about the efficacy of HVIP? So there have been a total of 5 randomized controlled trials of HVIP programs, 2 pediatric trials, which I've shown depicted here, and then 3 adult trials, all of which have focused on repeat injury as well as violence and crime involvement. And the overall takeaway from the studies demonstrate reductions in repeat injury, as well as convictions. And there have been other related work that's looked at the cost effectiveness and in some instances actual total cost savings for implementation of HVIP programs. And so this slide depicts the 3 RCDs carried out in the adult populations, with the intervention groups depicted in blue and the control groups depicted in orange. And what you can see from the 2 studies on the left, there were statistically significant reductions in repeat injury in the intervention groups. The one on the right had a slightly lower rate, but did not reach statistical significance. So, as I've sort of laid out, in many ways, the HVIP model is really well aligned with what we're sort of already doing as pediatric health professionals, right? So it's fundamentally an approach to connecting with youth in times of vulnerability. And I think in my own personal experience, working with the Hobby Network over the last 9 years, I think the sort of developmental lens and strength-based lens that we bring as pediatric providers is really synergistic with a lot of the work that takes place in this post-injury space. And I think that we have a unique role to be able to build bridges to either connect or reconnect young people with care. And when we're engaging or supporting young people following a violent injury, there are a couple of key topics that I think are really important to touch on that I just want to run through. And so first, key sources of support. Who in your life can help you through this? Circumstances of the assault. Do you know the perpetrator or others involved? Was it part of an ongoing conflict? Safety assessments. Do you have a safe place to live? Can you safely get to school? Risk for retaliation. Do you think you'll hurt someone because of this fight? Have your friends retaliated or plan to retaliate? Weapon carrying and weapon access. How easy would it be for you to get a gun within 24 hours if you wanted one? Mental health, with an emphasis on depression and post-traumatic stress symptoms. And here I want to put in a plug for actually then doing brief psychoeducation about traumatic stress and the various ways that it can manifest in the lives of young people, can really help normalize these symptoms and begin to open a dialogue about resources. And I think across all of these different domains, motivational interviewing approaches are really great for sort of building these connections and beginning to brainstorm what young people's goals may be towards recovery. And so what are the tips that we can use to actually connect with young people to promote recovery? I want to share actually an excerpt from Youth Violence, which is a chapter within Reaching Teens, which was co-authored with 2 of my violence prevention specialist colleagues in Philadelphia, Carla Brown and James Aye, as well as Dr. Kenneth Ginsberg. And in this passage that I'm going to show in a second, Carla and James were sharing their expertise about how to connect following a violent injury. And so I'm going to read here. So engagement happens when teens believe that we are open to understanding their circumstances, free of judgment or preconceived ideas. When we validate teens' experiences without referencing our own, and we're willing to share a degree of vulnerability without shifting focus away from their experiences or dilemma. Honoring youth as experts of their adverse experiences and recognizing the strengths that they have applied to tackle tremendous challenge will facilitate meaningful connection. Taking a strengths-based approach is a great method for connecting, identifying, and building upon assets that are far too often overlooked or even punished. As youth-serving professionals, using an approach that presses engagement forward with non-judgment, honesty, consistency, and persistence is critical to restoring youth's power and control and helping them find a path forward. And, I encourage all of us that although violence is pervasive, that we have the opportunity to actually mitigate its effects through using approaches that we do every day that are focused on positive youth development, that are focused on resilience and trauma-sensitive practices, and really encouraging us to envision these encounters as opportunities to alter life trajectories. And here I've outlined what's known as the 7 C's model of resilience that again comes from Reaching Teens and includes confidence, competence, connection, character, contribution, coping, and control. And really as echoed in the writing that James and Carla put forth, that especially for violence involved youth, the pieces around competence, control, and connection are particularly relevant. And getting back to the cross-cutting protective factors from that Connecting the Dots report, helping young people identify who the important adults are in their life, who can be those strong sources of support. And when one doesn't exist, helping to link them to begin to build those relationships is profoundly protective and very much in our purview as pediatric providers. And I would also argue that really central to our duty as individual practitioners, as clinical practices, as health systems, is to actively frame our interactions, kind of design our clinical spaces with a healing-centered approach, and really leading all of these pieces with radical calmness and consistent empathy can help us to create safe spaces to help young people move forward from prior trauma without requiring disclosure as a prerequisite for support or resources. And I think this must be part of our guiding mission in order for us to truly address youth violence as a health equity issue. And in addition to building those connections and offering support within the context of clinical encounters, we also know that there is a strong evidence base to support linkage to mental health services when indicated. And in particular, trauma-focused cognitive behavioral therapy, or TFCBT for short, has been shown to be effective in treating symptoms of post-traumatic stress, as well as trauma-related depression and anxiety among young people exposed to a broad range of violence experiences. And we are very fortunate here in Pittsburgh to have many TFCBT trained providers, and I've included the website there where you can identify providers within the area. And there are additional evidence-based approaches for young people who have other multi-system needs. And I think the other true privilege of being a pediatrician is not only getting to engage with our patients, but also building relationships with families. And as we do this, so partnering with families to address youth violence, it's really essential here that we're also starting from a trauma-informed and strength-based approach to this engagement. And that we recognize that minoritized families may have had previous negative experiences with youth and family serving agencies, including experiences of oppression and discrimination, and that it's critical that we create space for families to share their experiences and acknowledge and validate the issues they've experienced. And I think this is really critical as a first step to empowering caregivers, to building ongoing partnership, and also to addressing the long-standing inequities that actually underpin exposure to violence. And I've been really thrilled to see the focus that's come out of the AAP in the last couple of years around firearm safety prevention. And here I've put forth the website that's newly released out of the AAP that contains a lot of resources around talking with families, around firearm safety and violence prevention. And there's also been a push to think about the role of pediatricians within the HVIP space. And lastly, I want to put in a plug for the Trainees for Child Injury Prevention, or T4CIP program for short, which is sponsored by the Center for Injury Research and Policy in Columbus, as well as the AAP section on pediatric trainees and the Council on Injury, Violence, and Poison Prevention. And I have the privilege of serving as one of the faculty mentors for this program and we actually have two trainee members in this first national cohort in our ranks here in Pittsburgh. And we will be leading a day of action on October 27th, focused on safer firearm storage that'll include multiple different events, including a webinar, a Twitter chat, and other ways to get engaged. So I encourage anyone who's interested to reach out, and we're happy to share those resources. And so in summary, I hope I made the case that violence is absolutely a pediatric health equity issue, and that the post-injury period is a critical time for prevention and intervention. And we all have a role to play, and we have a responsibility to the young people that we care for to be at the table when we're thinking about violence prevention programming. And so I encourage anyone who's interested to reach out and think about partnering with us in our ET3 efforts here at Children's. And that, we know as pediatric providers how to do this work. And we need to be leaning in to make sure that we're working together to keep all children and teens safe, healthy, and thriving. And I want to thank you so much for the privilege of being with you all today and honoring Dr. Wiener's legacy. And I want to acknowledge the sources of funding that support this research, as well as the programmatic work I talked about today, and thanking the young people that I've had the honor of caring for, as well as our Empowering Teens to Thrive team at UPMC Children's, including Sarah London, who's our lead violence prevention social work specialist, as well as all of the other organizations and partners who are working together towards a more just and peaceful world. And with that, I'm happy to take your questions. I've included our ET3 contact and referral information. So if you have any young people that you're interested in referring, please feel free to reach out anytime. Again, thank you.
Thanks, Dr. Silva, for a terrific talk. We do have a few questions in the chat, which I will go ahead. I've been asked to read off. The first is from Dr. Said. Thank you so much for your incredible work in presenting this to us. I was wondering, what anticipatory guidance can we as pediatricians work to identify and prevent gang involvement? What red flags should we look for those contemplating or being influenced to join a gang?
Yeah, thank you so much for that question. And I think it's complicated. There isn't sort of one question that you can ask. I think that in many instances, what the research shows is that young people often are joining gangs for multiple different reasons. Often a lot of it is driven by structural inequities and lack of opportunity for jobs or other paths forward. And there's often, entanglement between gang involvement and other mechanisms for earning an income, such as selling drugs. And so I think one of the key pieces is really taking a positive youth development approach and working with young people to identify sort of who are those key sources of support in your life. Are there people who are not involved in violence, who you're already connected to? And if not, are there ways for us to get you connected with mentors or other programs to help fill some of those times with other opportunities? And the second piece being really around employment opportunities and training, because I think that becomes a critical piece that goes hand in hand, and really helping young people find what it is that they're passionate about, helping them build the skills to work towards that, and then identifying opportunities for them to actualize on those skills can all be really important.
Thank you. The next one is from Dr. Mateo. Given the isolation caused by COVID caused by COVID taking away school supports while simultaneously increasing mental health challenges, do you have a sense of any emerging data of increased violence as young people go to school, or are we seeing a decrease as the?
So, it was interesting because it has very much followed these sort of waves of the pandemic. During the immediate lockdown time, in terms of the sort of community-based or peer-based violence, we actually saw some reductions initially, and then things sort of rebounded as work opened up here. And I think working closely with the Cure Violence team from the health department, what they've seen is that as sort of stay-at-home orders lifted, that conflicts escalated pretty quickly. And I think especially in that time when people were sort of allowed to move around, but still most youth-serving organizations were closed, was a really high-risk time. And now as places start to reopen, programs are starting to open again, there are now some additional opportunities for other outlets. And so we've seen some drops again, but it's been a tremendous challenge, and in trying to meet the needs of young people in this time when we're doing most things remotely, you know, the technology divide and lack of access to tech devices also broadens that gap of who's actually able to engage in virtual programming or not. And it's become increasingly challenging and shown us, you know, really the importance of in-person interaction being best to promote that engagement.
Thank you. We have one more. Have there been, this is from Magana, it says, have there been initiatives to also address or treat causes that may increase risks for youth to be exposed to violence? For example, I remember many of our young people in Albuquerque were exposed to violence in the context of substances, so managing opioid use disorder was often helpful in violence prevention.
Yes, absolutely. And I think that that's, you know, another area, in addition to us doing this work in really siloed ways in the violence prevention field, that there has been less attention to thinking about those intersections between violence and substance use. And I think that as the opioid epidemic has really come to the forefront, it's pushed all of us to think about these intersections even more intentionally, but these intersections have existed for many years. And so I think, yes, working together to think about strategies that address multiple forms of substance use, because we know that at the root of much substance use are also histories of trauma and other, you know, structural oppressions that drive some of the substance use. And so I think really the underpinning factors are really similar. And I look forward to more work in this space.
Yeah, no questions, there are opportunities. That concludes the questions. Let me double check I think the chat. We've answered the questions in the chat, and there's nothing else in the Q&A at this point. I wanted to say thank you again, I think, for a terrific talk, and thank you to everyone that tuned in this morning for the Wiener Award lecture. We'll be turning it over now, Colleen, to the meet and greet for a little bit of time that everyone can spend with each other if there aren't any other questions. Just want to take one last moment to open the floor in the chat if there's any Q&A, I should say. I'm sorry. All right, looks like nothing else is coming in. Thank you again, Dr. Solbon.
All right, thank you so much.
And thank you again to everyone else. Wish everybody a safe and happy day. Thank you. We'll go ahead and turn over to the Colleen, turn over to the meeting.